It's so instant and it's so satisfying. This was what my guest Jess Vanson said on why pessary fitting is one of her favourite parts of her job as a pelvic health physiotherapist. Results for women with prolapse can be instant and life-changing in a field where so much of what we do takes time and effort to see the benefits. Today, Jess joins me to demystify everything about pessaries, from common myths to what life with one actually looks like. So let's get into it. Just before we get started with this FitRight Pelvic Puzzle podcast episode, the information shared in this podcast is intended for education only and should not replace personalised advice from your healthcare provider. Some episodes include fictional case studies to illustrate common presentations and how a multidisciplinary team might approach them. These stories are entirely fictional and are drawn from a mix of experiences in clinical practice, so any resemblance to real people is purely coincidental. Hello and welcome to the Pelvic Puzzle. This is a podcast by FitRight Women's Health where we break down the different puzzle pieces of women's health with the professionals who can help you put it all together. I'm your host, Taryn Watson. I'm a pelvic health physiotherapist from Perth, WA. I'm a lover of early morning walks, coffee, red wine, and all things women's health and exercise. Now, let me ask you, do you think that pessaries are only for elderly ladies? Because today I'm joined by pelvic health physio Jess Vanson for this next episode in our season called the Prolapse Puzzle. And she's going to tell us why pessaries are most definitely not just for elderly women who can't have surgery. And she's going to help demystify a whole heap of other things about pessaries too. So I'm going to introduce Jess, who's been my colleague at FitRight HQ for nearly 5 years now and has worked as a FitRight instructor for a number of years before that. So I just need to tell you my nickname for her as a way of explaining why she's the expert guest in this space. So I co-own FitRight Women's Health with another Jess Hextall, who is a musculoskeletal physiotherapist. And our first hire at the clinic 5 years ago was this Jess Vanson. But that got very confusing, as you can imagine. So I quickly had to come up with a way of differentiating between the two. And a friend of mine suggested that I call this Jess Jessery Pessary, because I'd been so excited to have a second team member who could start a pessary clinic with me. So welcome to Jessery Pessary. Jess. Jess is a hybrid sports and musculoskeletal and pelvic health physiotherapist. After working in private practice and sports such as soccer, AFL, rugby and performing arts arenas and working heavily in the lumbopelvic hip and lower limb areas, Jess branched out in further studies in pelvic health to fill in the missing link between hips and the pelvic girdle. And in 2018, Jess completed a professional certificate in the conservative management of pelvic organ prolapse through the University of South Australia, which sees her in this extended scope practice of pessary fitting. So Jess, can you add to that and let the listeners know what your work week looks like now and what types of patients you see and how much of your work life is focused on prolapse management and pessaries?
Yeah, thanks, Taryn. Thanks for having me. I would say that the majority of my week is working with prolapse currently, whether that be in clinic seeing women one-to-one to talk about conservative management of prolapse and pessary fitting, but also running some exercise classes and trying to help women feel like they can move their bodies safely in and around prolapse. So I have a bit of a combination of running classes, but majority in clinic. And yeah, I see, at least 2 pessary fittings or follow-ups each week, I would say, as a bare minimum.
Yeah, great.
Yeah.
And so just to remind listeners, in this series already, we've met some examples of fictional case studies who may end up benefiting from a pessary for their prolapse symptoms. For example, we've spoken about the mum of toddlers who wanted to get back to running, but she's limited by her prolapse symptoms. We've talked about a woman in her 40s who tried Kegels, but has now realised they were never likely to help the type of prolapse she has, and so maybe she's going to go down a pessary fitting path. Or the woman in her 60s whose bladder prolapse has worsened since she started lifting grandchildren more often. And these women, these fictional case studies, if they were in our clinic, they would no doubt have heaps of questions before deciding on whether they go down the path of pessary fitting. And so we imagined that you, as listeners, might also have heaps of questions like that. So we're going to deep dive into the top questions that we would get asked in clinic to demystify pessaries for prolapse management. So Jess, this episode we've called Demystifying Pessaries. So
Yeah.
let's start with you telling us one thing you wish that all women knew about pessaries.
They're not nearly as scary as they sound. They're not nearly as permanent as they sound. Like, yeah, that, pessaries are what we would consider a conservative management of prolapse. And there are multiple options for conservative management, pessary being one of them. And then we've sort of got more of our surgical management of prolapse. So, uh, what we know for any surgery is if we have a conservative option, we want to exhaust that first. Um, and yeah, pessaries are a very cost-effective, time-effective, non-scary option. And they cannot go up into your stomach. Okay. They stay in your closed loop vagina. They do not go anywhere.
They can't disappear into the
They
abyss.
they cannot. No.
Okay, good. That's a good one.
Yeah.
And on that note, for anyone listening who wants to know more about the surgical side of prolapse management, the previous episode before this was with Dr. Anna Clare, gynecologist, who backed up a lot of what Jess was summarising just then about exhausting conservative management and then the options of surgical management and the questions that women might have in the lead up to deciding on surgery. So back to pessaries. Tell
Yeah.
us, Jess, a bit about like what a pessary actually is and how they were historically used and fitted, and then what that might be like compared to today's use of them.
Yeah. Yeah, so look, you've probably got two parties that will fit a pessary on you, and that's going to be the urogynecologists, and then we've got our extended scope physios, such as Taryn and myself. And in the past, it probably was more in the gynae domain, the medical world, and they would fit a pessary on usually an older lady who couldn't have surgery. Okay. And it would be a put in place and leave it alone. And so they had a bit of a history of being for old ladies and they were a bit smelly and gross, yeah, because they were left alone for a long time. Um, and there were some of them were really rigid and hard and not so comfortable. Yeah, so they had a bit of a bad rep. And then I guess in the last 20 odd years, we're seeing more physios coming into it. And we really need a big shout out here because in the sort of early 2000s, Professor Patricia Newman, sort of in South Australia, she started developing some guidelines around use of support pessaries for prolapse. And that was sort of the training route for a lot of physios. And there are some other private physios now that do that training as well. So there's the Taryn Hallam's of the world and Melissa Davidson's who specialize. And so what happens is physios go and do the training. You've often worked in pelvic health for a long time. And then the physio will train and be competency-based training. So they're viewed to fit a pessary, and there are multiple different types. And then they can go and fit a pessary. So most pessaries are silicone-based, and they are mobile, rigid, not rigid, okay, like the old plastic ones. And they're all different types. So we're going to talk a little bit about that later. But yeah, it's like a little brace or a support for your vagina. Just like you might wear an ankle brace for a rolled ankle. Your ligaments have been injured, stretched, maybe torn. Your ankle now has a bit more mobility than it did previously, but it has a lot of function left in it. So what do we do to support it, to enable you to do what you'd like to do? We might put a brace on it or strap it or do something like that, just to give the body some assistance to enable you to do what you want to do. And that's exactly what a pessary is. It's going into the vagina. It's either sitting between the walls of the vagina, or it's supporting it a little bit more with a little bit more oomph, which we'll talk about again soon. And it's just there to help support the vagina, take the stretch off the tissues that might have been a little bit stretched, let the muscles kick back in again. But that's essentially what it is.
Put everything back in its anatomically correct or more
Yeah.
correct position. Yeah.
Yep.
As you know, I have been really proud of the way we've set up our pessary clinic
Mhm.
at FitRight HQ. It's unique. It's been challenging, but can you explain a little bit about our how our pessary clinic works and some of the things that we've had to consider as we've set it up and we continue running it?
Yeah, so like I said, initially we make sure that every physio that's coming in and wanting to fit pessaries have had that competency-based training. And sometimes they might only fit a certain type of pessary before they're then learning a little bit more. Then what we will do is that you're not usually going to come into clinic and be fit with the pessary on that day. So what will often happen is that you'll come in with your symptoms, and we'll then discuss at the end of that and after our assessment what's coming next. So what does that assessment usually involve? That initial one is something called a pelvic organ prolapse quantification. So if we were to map out the vagina, there's points in the vagina. So along the front wall between the bladder and the vagina, there is 2 points that we really focus on. Right at the top of the vagina, there's 2 points that we'll look at. And at the back wall, 2 points, and then there's another sort of 2 points at the bottom there that the opening of the vagina that we want to look at. So we assign all these little words to them, like genital hiatus and perineal body and D point and all these things. And so when you come in, we will be assessing those. We look at them at rest, but we also look at you bearing down because we'd like to look at how much flexibility your tissues have, noting that our vagina actually is a dynamic space and does move. So there's a certain amount of movement that would be considered normal. The other thing we might do is assess these points in standing, particularly the top, because we like to sort of talk about the vagina being three components, which I'm sure Taryn's talking about this, but there's the roof, the walls, and the floor, three levels there. So we want to look at those, but we particularly want to look at that roof in standing as well to see what happens when gravity comes along and sort of gives a bit of curry to that suspension roof. Um, then what we would do is like run you through what have we found? Yeah, you have a stage 1, 2, 3, or 4 prolapse. Which compartment? The top, the walls, the bottom, a combination of those things. We would have also looked at your pelvic floor. Okay. Um, then we would then discuss what are your conservative options to manage your prolapse. Yes, pelvic floor muscle training, pressure management. We're going to go down a huge list of things. And one of those on that list is a pessary. So then if I'm considering a pessary for you, I think you're a suitable candidate, then what we would do is we would send you, if you haven't come from a GP with a diagnosis of prolapse, you would then have to return to that GP. The reason being is that there are some reasons why there are lumps and bumps or bulges in the vagina that are not prolapse. And so we just need to make sure that that is actually what we're seeing. So once you've got that all ticked off by the GP and they're willing to co-manage with us, so that means manage any of the medical side of things and complications or observations like a speculum exam that we might need, then we can talk pessary. I would have probably sent you home as well with a handout on what is a pessary, what are the complications, what are the financial commitments and time commitments you need to make to fit a pessary. So you can go away and consider, is this something you'd like to try? Um, and then when you come back for your pessary fitting, we make sure you've got no questions, have no contraindications as to why we couldn't fit it. We size you up basically, like you're going for a shoe fitting. It's not like a shoe fitting, not as easy. And we try a pessary. And we're always going to start with something called an inline pessary, okay? Or a shelf pessary. And essentially, that one sits in the vagina. So I have a bit of a vagina and pelvic floor here. It sits in there on that pelvic floor, basically.
For
Okay.
those who are watching on YouTube, for
Yeah,
those
those
who
of
are
you that are watching.
listening, go
It,
watch on YouTube if you want to see what Jess is talking about with her silicone vagina she's just pulled out.
Otherwise, if you make a peace sign with your fingers, that's your pelvic floor. You turn it on the side, yeah? And then imagine you've got your vaginal canal coming up between there and the pessary sitting on top of that muscle shelf. Okay. It sits not up down. Okay. Our vagina actually, the first third is somewhat straight. And then if my tailbone's back to behind me, it kinks back towards the tailbone. Okay. and it's going to sit those inline ones like a piece of cheese. And then we've got other pessaries. If that one fails, we then try our other shoe types or pessary types, yeah, to find one that fits. So you would then fit the pessary, you'd stand up, we'd give it a test. So let's say that you have heaviness in standing, you stand up and go, oh, I can't feel my bulge anymore. Let's say that you have trouble emptying your bladder because your bladder's been kinking back. We'd make you go to the toilet, make sure you can wee. I could wee so much easily, I could empty properly. We might put an ultrasound on and check that you've emptied your bladder. So we give it a good test. We make you squat down, we make you bend over, we do all these things just to make sure that pessary is going to hold. And then you're going to take it out and put it back in again, because that's a really important step, is self-management, because we know women are far more satisfied with a pessary if they can self-manage. And then we would need to see you within 2 to 4 weeks, 4 to 6 months, and then at 12 months. And you put on a recall system. Okay, so you will get emails and reminders that you need to come back. We will chase you up. You also put on a database so we can track you along. Okay, it is a medical device that's put into the vagina, so there are rules around how we use these things. And so ordering one off Amazon and trying to fit it yourself, I don't recommend, because often it's going to fail and you're going to think that you've failed pessary management, which is why coming in, being fit for it, testing it, trying them all is really important, because on average it's 2 to 3 before we find the right pessary. So if you've tried one, you go, no, it didn't work. You haven't tried them all. You haven't tried the right sizes. So that's how it all works, and persevere, because if we can get through a month of using that pessary, 65% of women are going to continue to use that pessary. But if we're sort of, like tripping at the first step and then giving up, we might not have exhausted the full effect of a pessary.
Yes. Yeah, that's all totally that's such a good overview of like what we go through. And I think that that probably demystifies for people how the process of fitting a pessary and how we've had to set up that system, making, like you said, making sure that people don't get lost along the way, minimizing the risks, the medico-legal risks for us and the risks for the patient, co-managing with a GP, having lots of different sizes and shapes available there for us to fit with people, all the documentation and the letters back to the GP and the mentoring that we do it within the team. And it really is, like I said, it's a clinic service that I'm really proud of us having set up, and you've been such a huge part of that. And I think it's really, really good for women to know how much goes on behind the scenes that we're thinking about to ensure that they have the best chance of success with this and that there's no untoward negative consequences with it. One of those big misconceptions about pessary use, and you touched on this, is that as well as thinking it's just for old ladies who are not surgical candidates, kind of in line with that, I think a lot of people think of it as a set and forget thing, like a thing that a doctor puts in, and then that's just it for 6 months or 12 months or something, and then it's the doctor or the GP or the gynecologist who takes it out and cleans it or replaces it or something. Can you just talk a bit more about that whole self-managed versus non-self-managed aspect of it and why that's such an important part of decision making when we're fitting somebody with a pessary?
Yeah. So generally, if you're coming to see a physio who does the extended scope of pessary fitting, you need to be able to self-manage that pessary. It means you need to be able to put it in and take it out. Because if you developed a complication such as bleeding, pain, inability to wee or poo, you can take that out. There are a subset of women who might not have the dexterity or ability to do that. And so on occasion, they may come back to see us more regularly than that set schedule of 2 weeks, 6 months, 12 months, that they might need to see us every 2 to 3 months. But that is in coordination and collaboration with the GP or the gynae. Okay, so because we need to all be aware what's happening and that these women are being followed up. So if I fit that pessary, then I would definitely have you on a more frequent recall system. But in general, even the women who are like, no, I can't do that. I don't want to touch my vagina. I don't want to look at my vagina. I don't want, I can't do that. I can't get my hand down there. eventually what happens is no pessary is put and leave. The vagina is dynamic, so there will be movement. If you have a really large bowel motion and you strain, the bowel motion is going to sort of somewhat push on that. If you have a recurrent cough or you get sick and you're coughing, sometimes it can move down. So we, on occasion, do need to push it back up again, okay? Because the vagina is not a rigid pipe. So what we want you to be able to do is to know how to do that and to take it in and out, because your satisfaction with using that pessary is going to be a lot higher and you're going to have far less complications.
Mm. Yeah. I think another thing that women maybe have a misconception about, have some questions about,
Mm,
is how much their life is going to change with a pessary in. You know, like,
yeah.
am I going to be aware of it? Can I still have sex with it in? Can I
Yep.
exercise with it in? Can you explain a bit about like how a pessary and having a pessary fit inside would affect or not affect the way you live your life?
Yeah. Generally, when the pessary is in and it is in those upper two-thirds of the vagina where there's a lot less sensation, you shouldn't feel it. It should reduce your symptoms of prolapse, whether that be bulge and heaviness or a urinary type symptom. So it should increase your function. And women can certainly exercise with it in. That's the whole purpose of it, is to put it in and give you the confidence to go and do what you need to do. Because the weaker we get, the more deconditioned we get, the more pressure we're going to put down on that prolapse. It's a vicious cycle. So pessaries, yes, some pessaries you can leave in for having sex and having a period, let's say. There are others, though, that take up a little bit too much space in that vagina and they would need to be removed. And so these are things that we will discuss with you, and we need to make sure that we're getting the right pessary that suits your lifestyle as well as your prolapse. But
Yes.
yeah, but
And
generally, you put it in, you do your normal activities, you gradually increase your activity. So it's not like you put a pessary in and then you can go lift 120, deadlift 120 kilos. You know, we still need to do our graded exposure and increase our exercise over time as we normally would. But yeah, it should help reduce your symptoms.
yes, and there are examples of that. Like you said, that's the whole point of fitting a pessary
Mm,
sometimes. There are examples of that that if the listeners haven't listened to the previous episodes in this series, there's one about a woman who gets symptomatic for prolapse when she's running. And so that would be an aim perhaps for someone like her, fitting a pessary and then doing a graduated return to running program. That's the whole
yeah.
point, is trying to get her able to do that in an asymptomatic way. And then another example of a woman who has been told she needs to lift heavier weights and do some impact training
Mhm.
for her bone density,
Yeah.
but she can't because she's too symptomatic for her prolapse. Again, the whole point of fitting a pessary is to allow these women to be doing the things that are good for their overall health, mental
Yeah.
health, bone health, heart health,
Yeah.
without being limited by their vaginal symptoms, right?
Yeah.
Like that's the whole point. And like you
Yeah.
said, when it's in, you shouldn't be aware of it, but also that's one of my favorite things about pessary fitting is seeing how it can change the way that that woman's symptoms feel immediately, you know, like putting it
Yeah.
in. And then not only are they not aware of the pessary there, but they're aware of an absence of symptoms for the first
Yeah.
time in maybe many months or many years. And that can be,
It's so good.
I know it's so good. I've had the word life-changing used by
Yeah.
patients multiple times with that absence of symptoms all of a sudden.
100%. Yeah.
Yeah. And when that can be an option to have symptoms taken away so quickly like that
Yeah.
without surgery, it is really important for women to know that this is an option for them to at least have a go of before considering surgery in a lot of cases. I think.
Yeah.
Yeah.
The most recent sort of guidelines and research is pointing that every woman that has prolapse, if they can, should be offered a pessary as a first line management.
Yes.
Yeah.
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 On that note, though, what
Mm,
there are sometimes downsides to pessary use.
there are.
I don't
Mhm.
want it to, on this podcast or in clinic, I never want to make it seem like pessaries are completely risk-free.
Mm.
They have many fewer risks than surgery, of course, but Jess, can you explain a bit more about some of the risks or possible complications of pessary use and how we go about minimizing these?
Yeah, definitely. So, look, if we were to list that, and on our handout that we give you, it's going to list from most common to least common. And some of the risks, yeah, they can be considered quite serious. But the number one, like 30% of women, they're going to complain of increased vaginal discharge as the first thing, the most common thing that we hear. And sometimes that's just because we put something into the vagina. The vagina is a self-cleaning thing and it makes more of the discharge. But look, if it's not necessarily an issue as long as the discharge is not discolored or smelly. So sometimes that can indicate something called bacterial vaginosis or an infection. Then we've got things like if we ignore the pessary um, or neglect it, and there are signs and symptoms of wear and tear in the vagina. So it can rub. So if you have a shoe that is too tightly fitting, we can have a blister develop. Similar here. So the vagina is not dissimilar to the inside of your mouth. It's a mucosal kind of structure. And if we were to rub at one point and we were, let's say, a little bit thinner in our tissue or low estrogen, so around menopause, around birth, and when you're breastfeeding, things like that, when your estrogen's a little bit lower, we can get a little bit more wear and tear in the vagina, or the pessary is too large and it's rubbing and putting tension on. And so we can get things called like little ulcers or erosions. And if we were to ignore that, so like brown discharge or light pink blush discharge or frank bleeding, then that could rub a hole between the vagina and the bladder, or the vagina and the bowel, and then you would leak urine or feces or poo from your vagina. But again, that takes a while for it to get to that point. Pain. So again, a pessary that is well fit and high up should be fine. And you shouldn't have any discomfort. Okay. So you shouldn't really feel anything when it's in there.
Mm.
And then we have things like new onset stress urinary incontinence. What does that mean? It means that we put a pessary in, we kind of unkink the urethra, if you like, and the urethra is a little bit open and we leak more urine. It just might mean we need to fit a different type of pessary. That's called a continence pessary. That's got a little bit more support for the urethra and the bladder. And that might settle over time as well as we strengthen muscles.
Yeah.
Then we have got an inability to do a wee or a poo. Again, if it's too big and it's getting in the way. Then we've got the inability to retain or keep the pessary in. It falls out on going for a wee or a poo, or it slips out upon standing. Again, it's not big enough or not the right type. On average, like I said, 2 to 3 before we find the right type. So persevere and don't give up after the first one if it fails. And then we come to sort of, I guess, our more sort of serious end, where we might talk about neglected pessaries, where we get something called incarceration, or the tissue growing in and around the pessary. Again, that pessary has been left there for a long time and neglected. Okay, I'm talking years generally. And then we've had one case of cancer of the cervix, again, a neglected pessary. And look, technically, if you've got an infection and that could lead to death, sepsis and death, then yeah, the pessary could do that. But again, we're talking very low risk for those things to happen because of the follow-up and recall system that we have in place.
Yes. And that's why I was saying before about why we take this so seriously about follow-ups and
Mhm.
about gaining informed consent and explaining all of this
Yeah,
to women and having handouts that remind them these are the things that mean you need to take your pessary out or come and see us to take
yeah,
it out or present to urgent care to get them to take it out.
yeah.
But I guess the bottom line is, isn't it, that these almost all of those things you said
Mm,
in a well-managed pessary where they're following the guidelines that we set. And if they experience those things, they know to take it out and they've been taught to take it out,
yes.
then the risk can be mitigated quite easily
Yeah,
compared to, say, some of the complications that might come up with surgery. And again,
yeah,
you can go back and listen to Dr. Claire's episode about surgery, and she talks about she touches a little bit on the risks with surgery, but she also touches on that in that episode about using a pessary first before surgery and seeing whether some things like Jess was talking about unkinking the urethra and maybe unmasking stress incontinence, sometimes you don't know that that's going to happen until after surgery, and then you wake up from surgery with a new symptom that is going to
Mm.
be a little bit tricky to undo. But if you put in a pessary and unmask that symptom and realize that that is how your anatomy is responding to everything being moved up, then there's non there's a lot more non-invasive ways of managing that, and knowing that that could be an outcome from surgery might be an important part of somebody's decision-making process. So again, I think that these potentially negative outcomes of pessary use are in a different category to the negative outcomes from surgery in a lot of cases, aren't they? They're a lot more
Yeah.
reversible.
Yeah.
Yeah.
Most definitely. Yeah.
The cost of pessaries, Jess, that's something that comes up a lot. And if again,
Mhm.
if we're comparing with surgery as well,
Yep.
some women ask about the cost of pessaries, or more correctly, the cost of the pessaries used in the fitting process, plus the cost of the fitting consult, the cost
Mhm.
of any other follow-up appointments, and it can all add up. But yeah, what's your
Yeah.
thought about comparing this cost effectiveness versus the potential cost of surgery, and how would you answer somebody's questions about how much this is going to cost from a financial point of view?
Yeah. And I think it's two sides to this. There's financial cost and time cost and function cost. So if we just go financial cost first, um, probably fitting a pessary and having to come and see us on that sort of at least 4 times in a year, um, it's probably more cost effective than um, surgery initially. So whilst yes, it's expensive in the private world, once you have that pessary in place, it's like buying a really good pair of shoes. Yeah. You've spent some money, you've invested in a really good pair of shoes. They're going to last you however long. It's going to help with your foot pain. Same with the pessary. Once you've invested in that initial outlay and then everything's going well, cost wise over that first year of seeing physios and the pessary fitting fee, maybe a GP once or twice in there. Like it's maybe around that 1,000 to $1,200 mark. Like it's not too bad. Like as a standard fitting and follow up. Um, I think it's a really cost effective way of investing and trying conservative management. When then we look at and then your function, you're like, wait, you're back at it, yeah, and increasing your activity and doing what you need to do and you're weaning properly and etc.
And not having to
And
take
not leaking
6
when you're
weeks off work.
exercising. Yeah,
Yes.
yeah,
Yeah.
yeah. You might need to take a morning off work to come and see me, but I've had women bringing their children. Like I've fit with a toddler and a baby in a room, and
Mhm.
yeah, so we can make it work. But when we talk surgery, you've got the cost to see a urogynecologist, and they're a lot more expensive than us, and their wait list is huge as well. So you might be on a wait list for 6 to 9 months to see a urogynecologist to talk surgery. And in that time, you could have tried a pessary and be supporting your prolapse and your pelvic floor in that time. And then, surgery means, yeah, downtime and often permanent restrictions by your surgeon. And there are, every surgeon has their rules and what they will tell you, but often women are given a restriction on what they can do after surgery because of some of the failure rates. And, don't lift over it's most commonly 5 kilos or something ridiculous. And we do have research to show that that's not quite what we can do, but there's a function cost, time off work. Women who have had young children, like you can't take 6 weeks of minimal rest and doing nothing. You've got kids to look after, and so the downtime and then the restrictions on further future function can also be a cost. Okay, so not just financial cost. And
Mm.
Pessary is a good long-term option. Like we know if you're self-managing it, it's going in and out. You're doing all, your recalls. Um, it's a really good, cost-effective, function-effective intervention.
Yes. You mentioned this just then, but
Mm.
I wanted to just touch on before we finish a little bit about using a pessary in the lead up to surgery. We've touched on it a bit, but I know you and I have
Mm.
spoken recently and attended a research update recently
Yep.
where the idea of using a pessary in prehab in the lead up to surgery
Mhm.
was talked about. And can you explain a little bit more about why a pessary might be a good option in that wait time, perhaps in leading up to surgery or leading up to seeing a gynecologist or a urogyne to talk about surgery?
Yeah, so when we talk prolapse, we're talking about a connective tissue disorder. So where the tissue has been injured or stretched a bit. And so we've got more mobility in that vagina and movement of pelvic organs. So what can happen is that prolapse can stretch down onto that pelvic floor, so that little V. And if it's particularly like a bladder or a uterus, it's pushing and opening that pelvic floor, it's putting on stretch. And that pelvic floor has a really tough time working then. If the prolapse is below the level of the deep pelvic floor, like it can't help it. So what we do, and if you think about if I was to have, some glad wrap tissue and I'm pulling on it or pushing through it slowly over, 12 hours of the day, it gets stretched, more stretched by the end of the day. So if we use a pessary to help support that connective tissue, the pelvic floor then doesn't have a chronic stretch on it. The connective tissue doesn't have a chronic creep or stretch on it, and it can then stiffen up. Yeah. So the pelvic floor can work more, it can hypertrophy or get bigger. It can also then tension or pull onto that connective tissue, which helps stiffen that as well. So it is taking it out of its position of stretch, allowing our normal physiological function to resume, and it can help. Yeah. So
And
it's putting
then
that pelvic floor in a better position before you go to surgery. So there's lots of other surgeries that we know, like total knee replacements, hip replacements. People are meant to have prehab. So they go and do exercise to build the muscle up. Because if you go into a surgery with weak muscle that's wasted away a little bit, then we know that coming out of surgery and pain, like it's going to be a lot harder to pull back.
yes. Yeah.
Yeah.
So the mix between getting everything as strong in the muscles as strong as possible,
Yeah.
also getting the connective tissue potentially taken off stretch for a period of time, the
Yeah.
the chance that that will thicken up and harden up and be in a better position for the surgeon to do a surgery that is more likely to last and
Yeah.
be a successful surgery is important. And there's going to be a proportion of women who are doing that as a prehab for surgery and then might realize 3 or 6 months down the track that their symptoms are reduced
Mm.
enough to make a decision not to have surgery.
Yeah. Yep.
So it's good for if they do end up having surgery, and it's also good for
Yeah. It's a
double and triple
win-win.
checking that they definitely need that surgery and that there's not another option for them first. So
Yeah.
yes, again, you can go back and listen to Dr. Claire's episode on this, and she touches on that too about about what the rates of recurrence are with surgery, and about how the lead up to surgery and what you do in the lead up to surgery could make that recurrence rate better or worse potentially. So,
Yep.
time for my final question, Jess. Can
Yep.
you think of a recent moment that's reminded you why you love working in this space so much?
There's been a few of late. Like if I just go a woman who's just had a baby, and postnatal depression, anxiety, uses exercise as her crutch and but has prolapse. And you put a pessary in and now we can start our greater return to exercise and we know how much exercise is an important intervention for that population. And then, my elderly lady who isn't weaning properly because her bladder's popping back out, and then we put a pessary in and she's like, I just did the best wee of my life, and we know that women with these urinary retention symptoms, they can make cognitive symptoms like so dementia and things like that worse and urinary tract infections and all of that. So um it's 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 almost instantaneously satisfying and I love it. I love fitting a pessary. I come from a sports world where I fit other braces and do other things, and it's so satisfying to get them moving. And so yeah, popping the pessary in, getting them doing their pelvic floor muscle training and general global strengthening weeing properly, voiding properly, and their symptoms are reduced within a session. I don't know of any other physio, like it's so instant and it's so satisfying.
Hallelujah. I
Yeah.
totally agree. I
Yeah.
think, yeah, I really, really love this aspect of our work, and I love that we've got this option in our tool belt. It doesn't suit everybody, but it suits quite a large proportion of patients that we see. And to
Yeah.
give them that option is I think really important so that they know that that's on the table.
Yeah.
Thank you so much, Jess, for being my guest today.
Well,
Jessery Pessary. And thank you to the listeners for tuning into the Pelvic Puzzle podcast. If this episode resonated with you, I'd love for you to share it with a friend or leave a quick review. That would really help other women get access to this kind of information. And if you're looking for support, Jess and myself and the rest of the team at FitRight Women's Health is always here to help. Our women's health clinic is in Applecross, WA, and we also offer telehealth appointments. You can find links to book an appointment or an exercise class with us in the show notes. I'll catch you next time as we keep putting the pieces of the puzzle together and saving the world one pelvic floor at a time. Thank you again, Jess.
Thanks. Bye.